field. I'm one of the acute care surgeons here and the medical director of the surgical intensive care unit. I am going to talk to you today about death by neurologic criteria, previously what we always called brain death, and a pretty narrow focus even on that, just on the anatomy and apnea exam. So not a lot about the history of it all, which is, a lot of that's interesting, but kind of the nuts and bolts, really practical aspect of the exam. I don't have any financial disclosures, so sorry I'm referring to you all as students in my objectives here, but I guess we're all students. So at the end of this, I'm hoping that we'll be able to describe the anatomic areas of the brain as they're related to the diagnosis, and in addition to that, describe the elements of the exam, including the apnea test. So I said I wouldn't give any history, but I sort of have to talk about the American Academy of Neurology summary statement on determination of brain death, because this is if you fall asleep while I'm talking and you want to go, which one, this one? Pardon?
You may need a brain death.
I know, right? Exactly. And then when you wake up from your coma or your stupor, you can pull this document. This has since been updated, but it describes in detail like all the prerequisites, the exam, everything you need to know. So this is a lot of what I'm going to talk about. And then this in 2010, an update was published, but it largely incorporates almost all from the purposes of what I'm going to talk about, which is the exam and apnea test. That almost is unchanged. The few things that are changed between these two, if you want, sort of the Cliff Notes version without actually reading the two practice guidelines, is this first statement, which is that physicians making a determination of brain death will be intimately familiar with the criteria and have demonstrated competence in this complex exam. So the AAN is kind of pushing for what amounts to like ACLS, so that you kind of have taken a course and you have a little pocket card that says I know how to run a code, and just kind of the nuts and bolts that I know how to go through the exam, and I've demonstrated that in some kind of course. That hasn't exactly materialized, but that's their sort of aspiration, if I can put it that way. The temperature for the purposes of documenting an exam is now established as greater than or equal to 36 degrees. Previously, a lower temperature was accepted. Also, they now, under certain circumstances, accept a single brain death exam. And we do here, I don't go a whole lot into our hospital policy for the declaration of brain death, but we do here under certain circumstances, and I'll talk more about that. And then SSEPs dropped off the ancillary testing list of studies. So those are the only differences. So you can pull one or both of those studies, and it'll pretty much tell you what's in my slides, or you can email me for my slides later if you want. So what are the diagnostic criteria for declaration of brain death? You need to have, before anything else, absence of clinical brain function with a known and irreversible cause. What does that mean? That means you should have clinical and imaging evidence of an acute brain injury that is compatible with brain death. So you have a patient who clinically is unresponsive, but their CAT scan looks pretty normal, then you have a problem, right? So you should have imaging and clinical exam that are compatible with this diagnosis before you proceed. And then we need to exclude any complicating medical conditions, and we need to exclude any drug intoxications or poisonings. And then the body temperature, like I mentioned earlier, needs to be at least 36 degrees. So Usually at this point, I have asterisks on this slide because it's the only slide you have to open your eyes just for a minute and look up here. Because if you can remember the things on this slide, then you don't need to listen to anything else I have to say. So the 3 findings that must be present in order to make this diagnosis are coma or unresponsiveness, absence of brainstem reflexes, and apnea. That's it. And essentially in establishing that, we are assessing the various anatomic areas of the brain. So the cerebrum, the brainstem, and the medulla. So for the clinical exam, as far as coma is concerned, you want to assess the patient for lack of responsiveness. I usually start when I'm doing a neurologic exam with first see if they just answer you when you say their name, make sure they're off all sedation, any kind of paralytic agent. That may all seem obvious to you, but occasionally, I've been called, to do a brain death exam and the patient's on propofol, and you ask, well, why is the patient on propofol? Well, because they won't stop moving. I mean, to all of you, I don't really feel like I need to say things like that, so I'm going to leave out a lot of that stuff. So lack of responsiveness to supraorbital nerve pressure, which is just a steady sort of, pressure that you apply to the supraorbital notch, temporomandibular joint, and you can also do sternal notch, and some of us use nail bed pressure. Essentially, the nail bed pressure can elicit a spinal cord reflex. So a brain dead patient, as you all know, can still have spinal cord reflexes. The reason to test it is to know that those reflexes are present or absent, because you don't want to go through this whole process of brain death declaration and then somebody notices the patient has what you ascertain to be a reflexive movement, especially if you're in the OR about to harvest organs and they do something, the patient has a movement. You want to know, as the clinician doing this exam and documenting the exam, what kind of movements might be elicited. Okay, so I put that in there, the nail bed pressure, but not so that we confuse it with a comatose state. You can still have those sort of reflex movements. And that's actually what I sort of talk a little bit about next, which is what are the pitfalls of this clinical exam? And it's all of these movements that can be associated with brain death that can be really tough. What you tend to find now in the neurology literature, and I don't know, I must have forgot to change this font down here, but there's this article in Neurocritical Care that does a nice job of breaking down. On my next slide I have a table of some of them, because I'm not going to exhaustively go through all the different reflexes you can possibly elicit, but they do differentiate reflexes which are defined as being stimulus provoked from automatisms, which can be spontaneous, oral movements or any other kind of spontaneous movements. So here's a horrible slide, right? Because you can't read any of it, but at least you can read the reference. So if you're curious, you can go back and take a look. And I find this kind of, helpful because I occasionally find these things. And I'm not I know I introduced myself, but just for, full disclosure, I'm not a neurointensivist. I'm not a neurologist. I'm not a neurosurgeon, right? So if I see the last patient that I did a brain death exam on that had one of these movements, whenever when I was doing the doll's eyes part of the exam, her trapeze, she would go like this. Her right shoulder would go up, and it was reproducible, and it didn't extinguish at all as I did it. And I was like, I'm pretty sure that's a reflex, but I took a short video of it and sent it to one of the neurointensivists, and the lady was going to get a second clinical exam by one of them anyway, but as you know, in our hospital, if you need 2 clinical exams, it has to be 2 different providers. So just so you know, like I'm not, I know a lot about this stuff, but I don't consider myself such an expert that if I found a movement like that, I wouldn't like double check it with one of my colleagues, like, hey, what does this look like to you? So in that situation, I was fairly convinced that, that she was still in a coma, or that her exam was consistent with brain death up to that point. But I did double check with someone. So that's kind of how I handle those things from a practical level. So these are all those things that are more or less were listed on that table, but these things can be compatible with brain death. And I know a lot of us get told various things through the years, and like patients that are brain dead can have, for example, normal blood pressure or even sudden increases in blood pressure. They don't necessarily have to have diabetes insipidus. They can have dependent reflexes and Brainstem reflex. They can have, you'll see a triple flexion response, which is if you do like noxious stimulus to the leg, they'll flex their hip, knee, and ankle at the same time. You'll see, if you do a lot of these exams, you'll see all of these things. And the respiratory-like movements are weird because, especially if you're doing your apnea test and the patient does this weird kind of like shoulder elevation and they arch their back, it looks like they're taking a breath, but usually they're not. So, and this is just another diagram of some of the top one illustrates the triple flexion, the Babinski, and then this abdominal reflex. If you draw a cotton swab towards the umbilicus, you can get some twitching of the abdominal wall. So those are all things that you can have in brain death. That's not necessarily part of a brain death exam. You just want to elicit kind of movement to noxious stimulus, any kind of movement. But if you happen to do a more detailed neurologic exam, those kinds of movements can be present. All right, so then on from there to the brainstem exam. The brainstem exam, is an examination of the brainstem, which means essentially your cranial nerve exam, which for those of us, who haven't had to, recite say what they're responsible for in a long time, I have that nice picture. But then from the practical standpoint, how do we go about doing this? I usually start from head to toe with the pupils, because that's usually the first thing that we look at. The pupil should be mid-position. So for the mid-position, we say is 4 to 6 millimeters, or they can be dilated. There should be no response to bright light. And the pupillary light reflex, I have this nice couple pictures up there. As you can see, tests cranial nerves 2 and 3. Usually we move on from there to tests of ocular movement. There are two major tests of ocular movement are the Oculocephalic Reflex, or doll's eyes, which I was referring to before, and the vestibulo-ocular reflex. And I'm going to talk, the next couple slides go more into detail about how to test those. But I do have a note here. So for the oculocephalic reflex, we can only test if there's patient doesn't have any C-spine precautions. So, this is kind of fortunate for me because it makes my job really easy in trauma patients, because many of them, if they've had a blunt trauma and their C-spine is not cleared, which it's never going to be for the most part in this situation, you can't do the oculocephalic reflex, which simply means that the patient, if you can't complete all of the components of the exam, the patient always needs an ancillary test based on our hospital policy. So I don't have to deliberate, do I need an ancillary test or do I not, because almost all my patients, the ones that are on P4 for trauma, do anyway. But we'll go more into detail on that. So the oculocephalic reflex, we start off by making sure the C-spine is cleared, and someone has to hold the patient's eyes open. That can be sometimes hard, so usually like you're at the head of the bed, and it's easier for me with my right hand, so I usually stand on the left hand side of the bed. And then I like someone to stand at the foot of the bed, because that's actually the best place to see if the patient's eyes stay, to be consistent with brain death, you turn the head briskly from side to side. And a positive response is the eyes rotate to the opposite side, to the direction, so indicating that the brain stem is intact. So in the brain dead patient, let's see if I have a picture of this. Here we go. So in the brain dead patient, you can see the reflex is absent. The eyes just go in the direction that the head is rotated. Okay, so the person standing at the foot of the bed is in the best position to kind of see that. Does that make sense? The other test of ocular movement is what we call cold calorics, just like we have doll's eyes. So the vestibulo-ocular reflex, from the standpoint of performing this test, you want the head of the bed to be at 30 degrees so that lateral semicircular canal is in a more vertical position. And then I have this picture of this otoscope down here because most people don't know that an otoscope is part of a brain death exam. For the purposes of making sure there's no cerumen impaction and for the purposes of making sure that the eardrum is intact. That's more going to be in like the trauma patient, but the cerumen impaction can be in anyone. So usually if I have, this is a good like kind of how to make my life easier. If you know you're going to do a brain death exam in a patient, but you know they're a little hypothermic and you're trying to warm them up, or they're a little bit, their PCO2 is low, and you're waiting to start your apnea test with a PCO2 closer to 40. If you have some things you need to do before you can do an exam because you could tweak some metabolic things, in the meanwhile, send your house officer to find that, to find the otoscope and look in the patient's ears. Because otherwise, I guarantee you'll get to this part of the exam and you'll go, darn it! Like, now I gotta go find an otoscope. So that's a little tip that I've learned. Okay. So, and we just instill, there's no like right or wrong way to do this. You kind of figure out what you have at your disposal, what's easy for you to find, and what you sort of like more. You want to use iced water. We usually use, any kind of reservoir. You can use a kidney basin. You can use just those, they're those weird sort of pyramidal shaped plastic things. Get some ice, get some water. I usually use a tuning syringe and get some iced water in that. And then some people like to use a butterfly needle, cut the needle off, obviously, screw that onto a Luerlock syringe, the same size syringe. You can just use a tuning syringe and just, stick it in the patient's ear. You want to instill that slowly, so the patient's not reacting to water, they're reacting to temperature. So you're trying to lower the temperature of the ear. And then if the brainstem is intact, then the patient will have this nystagmus, like a fast speed nystagmus, but the slow phase will be towards the side that the cold water is going in. If you don't, what we'll see in brain death is nothing. Like the patient's eyes just stay dead center, just like for the doll's eyes. Like the patient's eyes just don't move at all. They don't deviate. So it's pretty easy to remember what the exam is that's consistent with brain death. And then the other thing is you're supposed to allow 5 minutes in between sides, because right now this ear is cold and we're going to go test the response on the other side. So ignore the middle here because we're not talking about reasons where, so brainstem intact, both eyes will deviate towards the cold water, and then brainstem not intact, the eyes will just stay center. All right. And then, so moving on from there, we can test cranial nerves 5 and 7 with a corneal reflex. So the cornea, you want to touch this actual sclera here. So this width is kind of held out, but you actually want to come over here and touch here, make sure you're not way out there, touch like right here. Gently, I usually use just the cotton tip applicators that you find in the patient's drawers, and you're just looking for the patient to blink. So be careful when you're holding their eyes open, you're not holding them so tight that you don't see them the blink, because you can do that. And then you do that bilaterally. You can also test the second branch of the trigeminal nerve with a nasal tickle by just tickling the swab inside of each nair and looking for a grimace or something like that. But that's not necessarily part of the exam. So, okay. And then usually, you know, we will have gotten some input from other people as far as whether or not they think the patient has a gag or a cough reflex, but we always test ourselves. So, you know, you can test with the Yankauer, the gag reflex, and then the coxobronchial suction is usually done with a Ballard suction. Okay, so the apnea test, so that was our brain depth exam that we went through, or the Brainstem exam. So we talked about coma, unresponsiveness, we talked about cranial nerve or brainstem, and now sort of moving on to the lower part of the brain, the medulla, we go on, we do an apnea test. So with the second of our two brain depth exams, we usually do an apnea test. The caveat here is that not every patient is going to tolerate an apnea test. And it's been a couple years, but it's never fun to do CPR in a patient as sequela of an apnea test. So I caution you to it's not required, it's recommended. If you cannot do a brain depth exam, then you definitely need to do an ancillary test. And that's consistent with that AAN guideline as well as with our hospital policy. So we try to do it. It makes us all feel more confident in our diagnosis, but just take that into consideration. So what you need to, same as before, the patient has to be normothermic, have a pretty good blood pressure, and that can be on vasopressors, and oftentimes it is. We pre-oxygenate the patient with 100% oxygen, and then we deliver 6 liters per minute of oxygen by nasal cannula. So the way that it's most practical to do this here is to cut off the nasal cannula prong, and then you have 2 pieces of plastic, tie a knot in one of them, and stick the other one down the ET tube. You want it to be at about the end of the ET tube, and usually you can tell that by the sort of markings on it. And that is going to allow you to give oxygen, but also allow carbon dioxide to not stay around. So you want the CO2 target is 60 millimeters of mercury, or it can be from their baseline to 20. So if their baseline PCO2 is 50, then you want to go up to 70. But when we say baseline, that's like not because we've been hypoventilating them in the hospital. It's sort of more their usual baseline. So, and then this part I put in red because this seems fairly obvious, but a lot of apnea exams that I've done here, people are sort of like chit-chatting and running around trying to figure out how to print labels from Epic and trying to get ice to put their blood gases in. And the whole point of this is to see whether or not the patient breathes, right? Really people should be kind of focused. You oftentimes need to take blankets off the patient's chest and really need to watch for respirations during that period of time. All right. It's always a good point. And then I sort of included this because I'm talking to mostly pulmonologists. You guys probably, find this more interesting and sort of you could probably more practically get into some of this stuff than I do. For me, usually my patient's going to need an ancillary test anyway because I can't do doll's eyes on them, and or they're too unstable for an apnea test, and I'm not going to be able to fix that in any way. But you can troubleshoot your apnea. So if the patient seems unstable or not, like they're not going to tolerate, you can try to repeat it again. So you initiate it and they become hypoxemic and or hypotensive, and you think they're going to arrest, then you abort. So you can try fixing whatever problem you think was causing that. and then go for it again. You know, what I tend to do is, okay, this is not safe, and go for the ancillary testing because I'm going to have to anyway. But then there's all these, you know, people get really interested in this stuff and they try to figure out ways to sort of circumvent or troubleshoot or make the apnea test easier. And I won't talk about all of these, but like for example, the first one is called CO2 augmentation. They actually give the patient carbon dioxide to raise their PCO2, and then so they get there faster, so the patient has less time to become unstable. Anyway, there's a lot of research on this in the neurocritical care and critical care literature, but none that have become sort of mainstream in terms of changing the AAN recommendations. So pitfalls, so pitfalls I talked a little bit about when you might need ancillary testing. Some people call it confirmatory testing. We try to say ancillary because if you are doing your exam the way we just described it, with, you know, assessing for coma and all your brainstem reflexes and your apnea test, if you do that exam by the AAN guideline, by our hospital policy, then there are none of those patients. You know, you hear in the media about patients that, you know, woke up or weren't actually brain dead. So if those guidelines are followed, there's not a reported case of patients actually not being brain dead. So if you do all that, then and you're able to do the number of exams you're supposed to do, then you should be able to make your diagnosis without ancillary testing. But there are a lot of circumstances in which it's needed. So if you have, like I talked about, what I see in my own practice most often is just the inability to perform a full clinical exam. So I can't do doll's eyes because the patient's in a C-collar. I can't do apnea because, you know, they had bilateral rib fractures and pulmonary contusions, and there's just no way they're going to make it off the ventilator for, you know, that amount of time for their PCO2 to rise. Also, and if we only need to do a single exam, which the indications for single exam for us are catastrophic brain injury. So, you know, you have a patient who has some sort of catastrophic injury where there's no question. This isn't the post-arrest brain death patient. So post-CPR, you always need 2 exams. But if your patient's a candidate for a single exam, then that's another instance when we need to do ancillary testing. Also, if cranial neuropathies, so and that's not as uncommon as you might think. So somebody who's had, you know, eye surgery is really common, and you might not be able to get a pupillary light reflex, or somebody's had has no eye, and they've been enucleated. You know, all these things you'll see fairly, not infrequently, I should say. And then if you have normal or inconclusive imaging, that one's up there. So that's the situation where I was talking about, where you have a patient who appears to be, you know, clinically brain dead, but there's no reason to explain that on their imaging. So some other reasons for proceeding with ancillary testing, I talked a little bit about this: facial trauma and other pupil abnormalities. And toxic levels of drugs. So there's a lot of, you know, argument on what was the level of the drug, how many half-lives, you know, what about if the patient's hypothermic, then how long does it take to metabolize it? So if there's any question, you know, this is always, you know, sort of an ancillary test might be in order. Or if you think there might be some toxic, you know, toxin on board that's just been unidentified. You suspect it because of the circumstances, but you haven't been able to measure it, or we don't have a test for it or something. And then chronic CO2 retention, and that's sort of relative. I don't know that, you know, in some circumstances you can still do an apnea test, just it sort of is relative, depends on how bad that is. And so, in summary, this is sort of a repeat of my earlier slide with the asterisk. Sort of the takeaway point, you know, is that in order to make this diagnosis, we need to have both clinical and radiographic evidence of an etiology that would be consistent with this diagnosis and its irreversibility, and then coma. absent brainstem reflexes and a positive apnea test. Oh, okay. Oh, yeah, that's a. Yeah, no, that's because that. Thank you. I'll go right down as soon as we're done. So I think that's all I had for you. I hope that's sort of what you were